It's unclear. Okay, so straight over. We have Rachel Lieber, Hamid Hussaini. Tell our loyal fans who we are. Yeah. I'm from PointClickCare, VP Markets West.
I'm also with PointClickCare, the Chief Medical Officer for Acute and Care.
Yeah. Hamid Hussaini.
Yes.
So your name. Great.
Hamid Hussaini.
Okay, so you guys, we've had like PointClickCare on in the past, and it's been great, obviously. Love you guys. What is even going on right now?
Okay, so Hamid and I are living in the world of world health transformation. Yep. And trying to figure out who actually is going to benefit from this.
Do you have an answer? Please let us know. Is it large government crimes?
Yes. I'm a little concerned. We might be missing the point of getting money to rural doctors. So I want Hamid to talk a little bit more about this.
Is this like a hot take? Is this a HIMSS hot take?
Oh, might be.
So we're gonna have to mark that for myself.
I like it.
You know, so when I think of rural healthcare, I work in rural healthcare, guys. If you saw the hospital that I work at, shout out to Lakeland Community Hospital in Haleville, Alabama. That's where I work my 3 or 4 shifts a month. When I show up, there's 1 or 2 nurses there. We use faxes still. We have an EHR that hasn't been supported in about 15 years.
Perfect.
I write my orders when I put them into when I put a patient in the hospital.
Wow.
And I still get all any kind of feedback on a spreadsheet, and it's all made. So this is rural America, rural healthcare 101. And so when we start talking about what's this rural health transformation, money going to be, is it going to get to the people that need it? Is it going to drive quality and outcomes in rural America?
That's what I'm freaking talking about. Yeah. See, like the floor, defining the floor of rural health is actually like we don't have that right now. And the floor, would you say your hospital is the floor?
It's close to the floor.
You got to work in the fax machine.
The fax machine.
We do. We have 3 working hamsters, and so there's worse. Believe it, I've been worse, but it's a struggle.
The divide is very real.
The divide is real. We talk at the federal level a lot. We hear, Dr. Oz and friends, and God bless our colleagues all working at CMS now, but they talk about we'll get the hospitals all technology. AI is going to solve rural America. How do you AI-ify a hospital that doesn't have a supported EHR and has a bunch of faxes?
Amen. And it's like get the AI to send the fax. Think about it.
Do you get a robot?
Yeah, you get a robot.
Use its eye cameras to scan the fax.
It's sending the caveman TV with a plug.
What am I going to do?
Right, exactly. And so, as we talk about AI, we talk about technology in rural America. We don't bring a consultant sort of approach to this. We're just taking a book, putting it on a shelf that will never be read.
Yeah. Well, what do you think we should do?
So what's also fun about us is being a part of PointClickCare now, we also get to understand the plight of the post-acute provider. And with the rural health transformation grants, what we're learning from the providers we're talking to directly, they are placing orders in their acute EHR, and then they're referring that patient to one local hometown post-acute operator who might have a certified EHR. They very likely still don't have a certified EHR, and they need to walk across campus, walk into that other building and duplicate the order entry.
Yeah.
They want to assure that when the patient actually arrives, that the orders will be activated immediately. So what are they doing? They're double documenting. And that's in one town. Like if we can't solve the interoperability problem for your neighborhood hospital and your neighborhood post-acute provider, we're not going to do this at scale. So what we're trying to do is just look at these really hometown microcosm examples of where we're not interoperating, and PointClickCare is trying to focus on use of the grant money to solve those local problems. There's major concern from these hospitals that as the CINs come in and consolidate healthcare, they're picking up these small hospitals, and so the money's going to end up in the mothership, and it's not going to get used. So one doc we work with out in Grand Rod, Oregon, LeGrand Hospital, if they could just make a capital purchase with these grants to buy a CT machine, like that's what they actually need.
Which you can't do, right?
Which you can't do.
They're not letting
But that's what they actually need. And so we're trying to listen to those docs who are like, look, I need revenue driving capital investments that are actually going to help me have the patients be taken care of. But I also need to be able to talk to my post-acute facility because there's one in my town. Like that's a problem that Hamid and I should be.
Yeah.
in terms of, and just a little bit of context, because you didn't say it, you're coming from the payer and what was it? Yeah, acute and payer. Right, acute and payer.
Yes.
Trying to remember the PCC word. The acute and payer business connecting to the post-acute. Yeah.
Yes.
And so one of the problems is, okay, there's a lot of these different, there's clinics as well, there's critical access hospitals, rural clinics, all kinds of things. There's hospitals in rural settings. And the problem previously to access technology of various stripes is like the numbers of providers and the numbers of lives, the number of people who are covered there is such a low number usually that like a fancy company like Innovacor or whatever has this technology, potentially also what you guys do, wouldn't be able to directly contract with one of those small locations, right?
Yes.
And that's hopefully changing. There's like subscription models, there's things like that. So I don't know how we solve it necessarily, because the solution, as you noted, is like, oh, there's a clinically grid network, they're going to acquire them, they're going to do the referral thing, and then the money goes back to, like you said, motherships. Like, how do we solve that problem of being able to work with those smaller practices?
Here's what I love about rural health transformation. The states are, which we love states' rights.
God bless states.
God bless states' rights.
That's right.
The states that are doing this well are taking a two-pronged strategy.
Yeah.
They're saying, we've got to use some of this money for big state problems. Okay, we've got agencies that should look at getting big tranche funding and let's put it to work at scale. Right. But they're also saying, my providers need to make a business decision that in 5 years, they can pick up the check.
Yeah.
We don't have a sustainability plan with this funding. So they need to come to us and say, I'm going to use this money to buy a certified EHR. And eventually I'm going to be ready to absorb that cost because it's going to help me drive more revenue to my building. So I'm ready in 5 years. And I think that the more that those states show that they're actually listening to their actual providers of, I want to use this money to do this thing, and then make it easy for them to go get the grants, we're all on board for that. And if those providers choose certified EHR for post-acute, we're all in. We will help you.
They can't do EHR licensing, can they? Isn't that an excluded thing? Is there some work
there, I think, especially for post-acute, if some of the facilities
Maybe,
that are not on an EHR are able to do that.
Got it.
I think the deal is, if you have an EHR, if you're Epic, as an example,
they're basically saying you can't like use it to like upgrade,
or like to develop something new that they're going to commercialize.
Got it.
Yeah.
Listen to what you said. A lot of us on the EHR side are going, that's the last mile, that's the last facility. Am I going to reach them? Okay, well, we still need to try, because in your town and in La Grande, Oregon, they're not on a certified EHR, and they deserve to be. Like, from the time of meaningful use, we didn't get these dollars in the hands of post-acute providers. They're waiting for help. And I think this is the first way that we go, you need to be in the interoperability network. And this is the way to get the ground infrastructure in place to get you in the conversation.
Yeah. So I know for some states, they have put in incentives to get post-acute on, behavioral health as well. There are some states. And I know that Congress, we never know if Congress is around. Like, if they came to work that day.
I haven't heard from them in a while.
Well, they did talk a little bit.
It's the State of the Union.
But they didn't do that. I would love to be a congressperson, because it sounds like you don't have to go to work.
Wait.
Don't you think I'd be great at it?
Yes.
I think you'd be great at it.
Yeah,
I would definitely.
I would staff you.
You would staff.
Because I feel like they really don't do very much. Anyway, at the Senate Health Committee hearing last week with Dr. Tom Keene, many of our fine senators on the Health Committee were talking about, they were like, Dr. Keene, why didn't behavioral health providers get incentives? Blah, blah, blah. And so he's talking about it. Now, again, we don't know if they're ever going to come to work and do anything about that, but I know it's a conversation and it's important. It's, this might be our last shot to get the last mile provider.
We've got.
I think it is.
Got to do it.
Yeah,
it's time.
We're talking about the AI. So I got freaking Deloitte and McKinsey doing all of the procurement for all this data. I don't know what's going to happen.
Yeah. Nice. Okay, so what happens next? Right, the timeline. We're in the timeline right now. The timeline is happening right now. So what's
some states
right now?
Kicking butt?
Yeah.
Shout out to Alaska.
Alaska got a lot of money.
Not only did Alaska get a lot of money, but they also wrote the plan on how you get the money out the door really fast. And so other states are looking at the great state of Alaska going, oh, okay, there's a way to unlock the dollars. And I think we need to unlock the dollars pretty fast and show some outcomes that The money is in
They
the hands
have
of the
to, or they
providers, and they're actioning the technology, they're actioning workforce, they're actioning like we've got until October to get some real points on the board.
And what we need here is we don't need to bring, from a technology standpoint, interoperability standpoint, every hospital in America up to the Kaisers and the Mayos,
Right,
No.
right,
Cleveland
right.
clinics of the world. What we need is a literacy of technology and AI that drives value from a more of a global rural perspective. There's going to be some leaders and some laggards, but the point is how do we bring everybody in? I think that was the intent of this bill.
Yes.
If we're really looking
Yeah.
at the genesis of it.
Yeah, I
Yeah.
think absolutely was. And I think the industry is seeing it as a big boon for tech, AI especially. But as Lisa is famous for saying, AI should be deflationary.
Yeah, absolutely.
And it should reduce costs overall. And I think people are seeing it as there's so much money.
They're like, let me build.
Yeah.
I mean, I think the worst part about the worst part so far for me about Rural Health Transformation Fund and also the CMS Access model is the absolute mountain of like obnoxious LinkedIn posts where people are like, this is how we're going to make so much money. And you're like, no, that was not it. That was not it.
Not the point.
It should be deflationary. We have to deliver with way fewer resources.
Yep. Yeah.
Like
Yep.
far fewer resources.
Yep.
So that's a problem for us. Like, I don't know, like no more LinkedIn.
This can't be a 5-year infusion that at the end of 5 years we
It's
don't
gonna be
have,
high tech.
right?
Well, the
That
age-
can't be.
We don't have an
it's waiting for
economic-
the money. Like,
Yeah.
Yes.
viability
Yes.
yeah.
of the
Exactly.
of the rural healthcare system. So
Okay. So, fans, what are your last words? Anything and anything.
Last
It could be
words,
about your
please.
in the Venetian. It could be about what you're learning at home. It could be
He actually has a picture on his phone. I just
Listen.
wanted to show you
you
just to show how
know, in Vegas, in HIMSS, man, there's so many smart people here. I am the chief medical officer at PointClickCare. However, two things I know best are rural healthcare and duck hunting. And so this is we really talk about experts here. Like this is what I typically this is my son and I, and we
fix that to me. We'll stitch it in.
we duck hunt every year in Arkansas, and so
Oh my god.
I don't know that I can tell you the most latest greatest about everything when it comes to healthcare tech, but you know what I can do?
Duck hunting.
I'm duck hunting.
Do you not know that I'm supposed to go quail hunting with the Texas people?
Man.
And I told Michael Keys, who probably didn't think to say Hamid actually should go with you. Okay.
He doesn't hunt. I don't
No,
think
he
that he does.
He does not. He goes to my parties in Where's Texas.
Amazing.
So,
Amazing.
okay. Oh my gosh.
Awesome. Thank you guys so much.
Thank you guys. Did you want to say something real?
No, it's good.
Okay.
That was good.
Like
That's a good thing. I'm all listening.
Oh my gosh, that's fine.